All right, pharmacist interventions part 14. So yesterday I had a patient picking up Celexa, 40 milligrams, which is the maximum dose, or citalopram, paliperidone, 150 milligrams intramuscular injection, as well as trazodone, 200 milligrams. All three of these drugs have a warning of QT prolongation, which is a risk for palpitations and then a progression into an arrhythmia. So I asked her if she ever had an EKG, because usually a doctor will get like a baseline EKG, especially in patients who have like cardiomyopathies or any predisposition for that. But she did not have a baseline or even periodic EKGs, and she was on 3 drugs at relatively like high doses or like medium to high doses that would warrant EKG monitoring. So I recommended that she talk to her psychiatrist and see if they want to do that. Just as like a cautionary measure, especially when you're on these medications. It's definitely something you want to monitor with patients. I had another patient who was picking up, like, I kid you not, 1,080 hydroxyzine tablets. This was for a 90-day supply, and it was 25 milligrams. So I intervened on that, and I said, hey, this medication is supposed to be used as, as needed. It's not usually supposed to be scheduled every single day, like 4 times a day, like 1 to 2 tablets 4 times a day is a lot. I've never seen anyone try to pick up that many. I had like 2 bottles of 500 and then another 80. I was like, well, there goes all my inventory. But I did intervene on that. I had another patient who was picking up 3 inhalers. He was on Trelegy, which is a triple inhaler for COPD. It's umeclidinium, vilanterol, and fluticasone, which is a long-acting muscarinic antagonist, the umeclidinium, long-acting beta agonist, and then a steroid. So usually with COPD, you treat with a LAMA and a LABA, which is the muscarinic antagonist and the beta agonist. In patients with elevated eosinophils, we add on a steroid. But he was also picking up Spiriva, which is tiotropium, and Advair, which is fluticasone salmeterol. So he is basically on like way too much. So he didn't know which one he was supposed to be on. I recommended likely being on the Trelegy and then following up with pulmonology and seeing what was going on, because there's 2 different providers sending in these inhalers. Last but not least, I had a patient picking up naproxen, which is a 2-day NSAID, and meloxicam, which is a daily NSAID, has a higher risk for cardiovascular side effects, and he didn't know which one to get, so I recommended meloxicam and not taking both.